A very big hello to all my dear students. So, welcome to the T2O series of ophthalmology on your favorite channel, You and I with Dr. Ruchi Rai. So, how are you all? Let's see what we have in store today. So, we are going to discuss some interesting questions. But of course, first we'll start with a case study that is clinical vignette. And all those who are active on my Telegram group would also realize that there are questions in the quiz that you are attending every day almost. Some of the other questions are being posted, and discussion is very much connected to what is asked in the quiz. So I hope you all are very active there as well. Okay. Coming to this clinical vignette, let's see what it is. A 22-year-old male presented to the IOPD 2 days after a road traffic accident with decreased vision in the right eye. Okay, so after a road traffic accident, decreased vision, how much decrease? On examination, the visual acuity of right eye was hand movement. That much decrease. Okay, keep in mind, left eye is normal, 6 by 6. Extraocular motility is full. That means all the eye movements are normal, ductions and versions. Pupil, right eye showing RAPD, left eye is normal. Intraocular pressure in both eyes 14. That means IOP is normal. Anterior segment, again on slit lamp examination, when you're looking at the anterior segment, it is normal. Till now, what comes in your mind? So it's a case of road traffic accident, one eye, drop of vision till hand movement with RAPD. It could be an optic nerve avulsion or any trauma to the optic nerve that comes in your mind. Or second, what else? Let's see on the fundus examination. Fundus examination showing superficial retinal ischemia in the distribution of the radial peripapillary capillary system. Peripapillary का मतलब around the optic disc की जो capillaries हैं, there you are seeing ischemic changes, and because of that you see some changes on the fundus. Now this goes more towards what are the options. Let's see. Okay, so there is one option is traumatic optic neuropathy, another is Puschers retinopathy, macular hole or retinal detachment. Obvious hai, it cannot be. Why we are saying not traumatic? Because the fundus picture goes more towards Puschers. Okay, so ideally here we should answer Puschers retinopathy. Now, why it is no, what are the other option one retinal detachment? The presentation is very different, right? Similarly, when you talk about macular hole, again the cause and presentation can be different. How different? Especially the major difference that I would say is on the fundus picture. Correct? We'll have a look at the fundus picture here. So let's see what is Puschers retinopathy. Due to trauma, what is happening? There's occlusion of the capillaries that is causing ischemia to the retina. When there is ischemia, it is causing that drop of vision, right? So, why is there ischemia? Where is the blockage? Why it is happening? This occlusion could either be due to embolism or it could be complement mediated. So, it is mainly the trauma which is causing the microvascular damage, and that is leading to occlusion and ischemia. So Puschers is always after a trauma. Then we call it Puschers. Keep in mind. Head injury, chest injury. When you say Puschers like retinopathy, what is that term? Puschers retinopathy, the cause is trauma. This is the clinical picture. Now, when we talk about Puschers like means the cause is anything from apart from trauma. Keep in mind. So it could be like other than like acute pancreatitis. This has been your exam question. Trauma has been asked, but very important. What has been asked is acute pancreatitis, or because it can occur due to fat or air embolism. It could be preeclampsia. So all these can be causes of Puschers like retinopathy. So that's the difference, right? Okay. When you look at the fundus, what do you see? Here, let's see this. These are not cotton wool spots. See, cotton wool spots are these. These prominent ones, these are called cotton wool spots. Do you all know what are cotton wool spots first? So cotton wool spots are soft exudates. We call it soft because the margins are ill-defined. What are soft exudates? These are axonal debris. They are axonal infarcts. That is what is cotton wool spot. समझ आया? Okay. So We can see on fundus examination, whenever there is any, all this, can you see typically it is peripapillary around the disc. And what do you see due to ischemia? You are seeing axonal infarcts in form of multiple cotton wool spots. I can see hemorrhages here. Can you look at this one? Right? So I can see the flame-shaped hemorrhage is seen. And what is this picture? What is this? This is another picture here. Look at this one. This doesn't look like cotton wool. These are called Puschers fleckens. These are Puschers fleckens, and they are nothing but blockage of very small capillaries. Okay, so just remember this. Puschers fleckens are multiple superficial white retinal patches that you see due to capillary bed infarcts. Very small capillaries infarct, it will lead to Puschers fleckens. And otherwise, you all know now what is cotton wool spot. Correct? So क्या मिला हमें fundus finding? If you want to draw it for yourself, it would be good. And if I look at my fundus finding, what I see here is around the disc I am getting cotton wool spots, right? Multiple cotton wool spots around the disc, or it could be Puschers fleckens, right? This is typical of Puschers retinopathy, and of course hemorrhages, and of course flame-shaped hemorrhages. Right. Next we talk about is, once we know this, let's have a look at the other options that we had. What would be the fundus picture then? So this is how a macular hole looks like. It could be spontaneous, it could be due to trauma, but this is how it looks like. So fundus picture is not peripapillary, it is at the macula, right? So we will not mark macular hole. If I do the OCT, it's very typical finding is this. So on OCT, this is what is macular hole. So I included this so that you can learn with me what are the other findings of other conditions as well. So this is how a macular hole looks like. And what was the next? Retinal detachment due to trauma can be, that is dermatogenous or due to any break. But again, it has to be, it will always present in a little different way with the floaters, photopsia, curtain falling in front of the eye and so on. Okay. Here what you're looking at, this is a giant retinal tear which can be seen after trauma. Okay. But again, the findings are not peripapillary. In this question, we are talking about peripapillary findings. So we are going to mark the answer as Puschers retinopathy. Right. Correct? So this was one clinical vignette for you all. Once we are done with this, we will quickly take some interesting questions and try to solve it. It is including all the exams you can think of. Okay, these questions are going to be important for all exams, whether it is NEET PG or I'm talking about INI-CT or FMG. Okay, one of you had written to me that we are appearing for FMG exams and I should discuss accordingly. Every discussion is connected. Even if we are looking at the spot diagnosis, you're talking about Marcus Gunn pupil in my previous video, you will realize that of course you get questions on what is Marcus Gunn, sorry, not pupil, Marcus Gunn jaw winking phenomenon. Of course, Marcus Gunn pupil is also always a question, but that diagnosis or that video that you were looking at in my previous video, that small clip about Marcus Gunn jaw winking phenomenon. Of course, that is asked in FMG exams. So everything is connected. And every FMG student is going, has to appear for the NEET PG as well, isn't it? So please keep on studying. It's all connected. The best part about ophthalmology is that if you work harder in this, you are going to really cover the questions well because it's not that vast. You know? So it's all connected, and and I'm trying to take it in the most crisp way possible. Okay. Another thing is, before I go to the next question, suddenly I remember, okay, I should talk about this at the end. I'll talk about that. Let me talk about the questions first. Coming to this question number 1, I want you to first have a look at the picture. So you see some cataract changes. It could be mature, both. Generally, it looks like a mature cataract, not fully mature. But we cannot comment like this unless we are peeping in through the slit lamp. Let's see the question. A 65-year-old diabetic woman presents with a painless loss of vision. The ocular finding is shown. What is the likely diagnosis and management for this? So now the options itself is going to tell you the answer. It's very easy. Zonular cataract and lensectomy. Of course, we are not looking at congenital cataract. I hope you all remember zonular is the lamellar cataract, right? Then second is rosate cataract and sugar control. No sense. रोजेट शेप कैटरैक्ट कहाँ मिलता है आपको? ब्लंट ट्रॉमा में. Sunflower cataract and the lens, it should be lens extraction, I'm sorry. So sunflower cataract and lens extraction, of course this is not sunflower cataract, which is a feature of calcosis. Don't forget all these points. And immature senile cataract, and it has to be managed with phacoemulsification and IO. I think the best option, obvious, it's a very simple question. You should be able to quickly see that this is a case of cataract. And any cataract with a mature, immature, we would like to go for phacoemulsification and IOL implantation. Come to the next one. So the next question is this one. Okay, what do I see here? So what do I see here? Look at the first picture. I see a congested red eye and a little bit of haziness in the cornea. It doesn't look very clear. But what is most important, I can see vertically oval dilated pupil. दिख रहा है ना? So what is this? This is, let's see the question now. A 50-year-old female presenting with acute painful red eye. Image is shown below. What is the most likely diagnosis? It is not a constricted pupil, so it cannot be uveitis. Our answer will be acute angle closure glaucoma. It's very simple, right? So we answer acute angle closure glaucoma. Let's see to the next picture. Okay, if I look at this picture, I see that the clarity and the focus is disturbed. Can you see this? So the picture says which refractive error, the question says which of the following refractive error is associated with the image. When the image is not clear, you can see diffuseness in the image. What is the refractive error? Yes, very important. What will be the refractive error? It is astigmatism. Okay, so the answer would be astigmatism. You should be very clear about the types of refractive error. Okay, this is again a very important picture and it is so commonly asked in the exam, so many times asked even in INICT. So what is this picture? So you can see it's a large cornea, ophthalmos, hazy cornea and large ophthalmos, that is large eyeball, and hazy cornea. And of course the cornea size also. Very typical. So here the answer would be what? I'm not even reading the question. Let me read it. An infant is brought with the complaints of excessive watering of the eyes and photophobia. Image is given below. What is the likely diagnosis? Child with watering, photophobia. What are the things you have to keep in mind? Of course, congenital glaucoma. Watering could also be due to an LD obstruction. So we have to look at the causes. Yeah. So here answer will be, and of course another cause of watering in this age group, what you should think? If I talk about a small child and talk about watering, it can also be ophthalmia neonatorum, right? But this type of picture with ophthalmos, hazy cornea, this has to be congenital glaucoma. So our answer would be congenital glaucoma. Okay, we come to this one. What do you see here? So what do I see in this picture is inside the cornea is your intracorneal ring segment, intacs. So intacs कहाँ use होता है? What does this procedure indicate or what is the condition? We have to answer keratoconus, right? So keratoconus, very simple. Look at the options. Obviously the answer is keratoconus. So in this case, we can use intracorneal rings. Okay, again, I think this was a question recently asked. Again, this was one of the FMG questions that was asked. This is a foreign body on the cornea and how do you manage it? So how do you manage it? I'm not reading. If you want me to read, I'll read it quickly. But a patient presenting to you, pain and redness, of course, there is pain and redness, falling injury during welding. So some iron particle has gone and stuck on the cornea. What is the step? Of course, what we do is with the 26 gauge needle, we are just scraping the foreign body and then you bandage the eye, pattern bandage with antibiotic ointment. The next day, epithelium will regrow over it and things are fine, right? Whenever we are trying to remove the foreign body, what is the very important thing I want to see on the slit lamp? What depth? So I will make a slit and see what depth of the cornea it is involved. So here, if it is superficial, I'm not worried. I can use my needle and take it out. But I should be very careful till what depth this is. Okay, then only I should be trying to take out. Otherwise, I may puncture the cornea. Right? Yeah. Okay. What is this? I think this is, again, we all know, we are looking at KF ring. Repeated questions, so maybe that's the reason repeated discussion. So KF ring, we all know. Kaiser Fleischer ring, what are the points you should know? If I include all the exams, what they have asked, ICT, FMG and EPG. So every exam has asked about KF ring. क्या पूछा है? KF ring copper deposition है. Okay. What else they have asked you? I'm just listing the points. What else? Which layer? Descemet's membrane. Okay. What else? It starts from superior and inferior and then becomes a circle. Okay. What else? Then what else is all patients of Wilson's disease who have neurological complications. If there are neurological complications, then all patients present with KF ring. But only around 67% of the patients will present with KF ring if we are talking about hepatic involvement. So patients with hepatic involvement, not all patients of hepatic involvement will have KF ring. It is only around between 65 to 67%. Right? These are some of the most important points here. So our answer here is copper, right? And that's it. Nothing more. This is it. In and out about KF ring, that is Kaiser Fleischer ring. And I hope you are not confusing with Fleischer's ring, which is iron deposition in patients of keratoconus at the base of the cone. And this iron deposition, all the iron depositions, keep in mind, are always epithelial layer. Okay? It is from the on the epithelial layer. Okay. Maybe next time I'm also going to discuss with you about different iron depositions if you want. So we can talk about different iron depositions, which is important for you to know at your level. I'll make a video on that also. We come to the next question. Now, what is this? One eye is congested. Here it is all blanched. Question is given image vascularity of the blanching is occurring after 10% of phenylephrine. So phenylephrine test has been recently asked in the exam. That's why I included this question. So please, let's quickly revise. What is phenylephrine test? You have a patient with the nodule and congestion on the, you can see a nodular elevation on the conjunctiva and the congestion. Okay? Now you want to know what it is. There are three options. It could be flectanular conjunctivitis, it could be episcleritis, it could be scleritis. So how to differentiate phenylephrine test? What do you do here? You are first instilling 1% phenylephrine. Blanching हो गई, मतलब it was flectanular conjunctivitis. No blanching, increase the percentage of phenylephrine to 10%. Now, if you're getting a blanching as in this question, that means it was episcleritis. Okay, so the answer would be nodular episcleritis. But if even after 10% no blanching is happening, still red, then it is the deeper plexus is involved. That is why phenylephrine is not able to act here. Deeper plexus kiss mean deeper episcleral plexus. Where will it be involved? Common sense, sclera involvement. So in scleritis, there will be no blanching. Right? I hope it's clear. What are you looking at? This is a filiform type of ankyloblephron. What is ankyloblephron? Addition of the two lid margins. So we will answer here ankyloblephron. What next? So I can see in this patient, if you look here, right eye is esotropia, left eye looks straight, right? Convergence squint. Okay. So the question here is, it is associated with which refractive error? If we talk about accommodative esotropia, if you remember, where there is increased accommodation happening, it has to be associated with hypermetropia. Do you remember what is accommodative esotropia? Overstimulation of accommodation. We have learned theory. Let's revise the one-year reflex. When you are looking from far to near, what is happening? Convergence, meiosis, and accommodation. तीन चीजें होती हैं. When the accommodation is happening too much, sometimes because they are all linked, it causes convergence of the eyes. Why can it happen? It could be refractive, it could be non-refractive, or mixed type. When I say refractive, now it is related to this question, I hope you are alert. It is due to uncorrected high hypermetropia. Okay, you all think with me. What is hypermetropia? When there is less power in the eye. What is one method where the eye can increase its refractive power? By exerting accommodation. Contraction of ciliary muscles, relaxation of zonules, increased curvature of the lens and therefore more power. अब अब अगर you are not correcting the hypermetropia, the eye is trying to compensate this by exerting a lot of accommodation to compensate for that less refractive power. So what happens? Too much of accommodation leads to inward deviation, that is esotropia or convergence good. That is why if I want to just, as soon as I correct this child's hypermetropia, the ciliary muscles are going to relax, accommodation is relaxed, so now the eyes become straight. Why? Because I have corrected the hypermetropia. Now this is not a situation of less refractive power, so now my eye will relax. Hope it was clear. And can you also revise with me what can be the cause of non-refractive type? When the AC by A ratio is more. Accommodation, convergence, bar accommodation. Kitne accommodation pe what is the convergence? If that ratio, if the child is born with more ratio, even little bit of convergence and the if little bit of accommodation and the eye converges. Okay, I'll repeat it. I just said if the AC by A ratio, the child is born with more AC by A ratio. क्या होता है AC by A ratio? Per accommodation, what is the accommodative convergence? कितना eye converge करेगी? How much the eye will converge? So, it's a motor imbalance. If the child is born with more ratio, I am saying even little bit of accommodation it exerts, there will be more convergence. Right? In that case, again, this type is non-refractive type of esotropia. Okay, so here what will be answer? It will be hypermetropia. When it is refractive, the main correction is correct the hypermetropia and the problem is solved. But if it is AC by A ratio is more, how do you try to relax this accommodation so that convergence is corrected? So what we try to do, this accommodation is centrally, the message is going correct. What do you do when you give pilocarpine? You are causing that accommodation from the peripheral. So the central stimulus is lesser and therefore the convergence gets corrected. Okay? Or we can of course also help this child by giving near glasses. When you give the near glass, the accommodation will be exerted less because you have already given the plus number for the near. Right? Make sense? Okay. So that was all about a quick discussion all around these topics. I hope you enjoyed this discussion today. We are going to end, as a protocol, we will end by a thought for the day. All of you, let's read the thought for the day. Let's reflect here. So, victory in life is decided by that last concentrated burst of energy filled with the resolve to win. So I'm paraphrasing a very renowned philosopher. So let's again read his lines, what he's saying. So let's reflect here that victory in life is decided by that last concentrated burst of energy filled with the resolve to win. So why did I choose this? Because I want to convey to you all, dear students, that last burst of energy, which is only filled with the resolve that I have to do this. That is needed. And I hope you all are working towards it. Okay, thank you so much. God bless you. Stay blessed and keep smiling.